السلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله.
أسعد الله مساكم جميعا. صراحة مشرفني اليوم الأستاذ فهد، مشرف وحدة الرنين المغناطيسي، بإعطانا محاضرة قيمة. فالله يعطيك العافية فهد، وسامحنا أخذنا من وقتك، لكن الله يعطيك العافية حبيبي.
الله يعافيك يا أبو فيصل، وأشكرك على المقدمة الجميلة يا أبو فيصل.
والله تشرفنا بوجودك معنا، والله إثراء
الله
لنا.
يحفظك. الله
الله.
يحفظك يا أبو فيصل. السلام عليكم جميعا. Uh, Good afternoon, everyone. Today I will presenting on the role of MRI in prostate cancer, focusing on its use in staging and evaluation of multi-parametric MRI. So let's begin. I will briefly outline today's objectives. We will review the role of MRI in prostate cancer, including detection and characterization. Then we will cover prostate anatomy, key pathology features, and MRI appearance on T2 diffusion, T2 and diffusion weighted images, and ADC map. Finally, we will discuss the value of multi-parametric MRI in improving diagnosis and staging accuracy. So prostate cancer is a major global health concern and the sixth leading cause of cancer-related death in men worldwide. In Saudi Arabia, it is also the sixth most common cancer among males. Autopsy studies show a high prevalence of latent disease, increasing from about 30% at the age of 50 to up to 90% by age of 90, highlighting the importance of early detection and accurate imaging. So the primary role of MRI in prostate cancer is local staging, especially assessing extracapsular extension and tumor spread beyond the prostate. In practice, it is often performed after a positive biopsy to define disease extent for treatment planning. However, its role is evolving, and multi-parametric MRI is now also used for detection of clinically significant cancer and for follow-up after treatment. In the future, MRI expected to play a role through all the stages of prostate cancer patient pathway. This begins with detecting clinically significant prostate cancer, especially through multi-parametric MRI technique. MRI also remains essential for accurate staging, helping determine the local extent of disease and guiding treatment decision for the patient and for the doctor. In addition, MRI increasingly valuable in monitoring treatment response and detecting relapse or recurrence after therapy, making it an important tool in both diagnosis and long-term patient management. So the pathology for the prostate cancer. More than 90% of prostate cancer are adenocarcinoma, which arise from the glandular tissue of the prostate. One of the most important pathological grading system is the Gleason score, which reflects the aggressiveness of the cancer cell under microscopic examination. The Gleason score is calculated by adding the two most predominant Gleason pattern, each grade from 1 to 5, a higher Gleason score. Indicate a more aggressive and potentially more invasive tumor, a more invasive tumor, which is important for prognosis and treatment planning. So this slide summarizes the Gleason grading and scoring system in prostate cancer pathology. The Gleason grade range from 1 to 5, where grade 1 represent well-differentiated, less aggressive cell, and grade 5 represent poorly differentiated, highly aggressive tumor cell. The Gleason score is the sum of the two dominant grade defined in the tumor specimen. Clinically, Gleason score of 6 or 3+3 is considered a low risk, and a score of 7. So either it's 4+3 or 3+4 is classified as intermediate risk, while a Gleason score of a higher indicate a high risk disease with more aggressive behavior. So I'm not sure why there is a red line in the slide. I want to remove this red line because it's maybe it's affecting the slide. Accurate staging of prostate cancer is essential. It directly influences treatment selection and overall pattern management. MRI plays a major role in local and regional staging by providing excellent soft tissue contrast and anatomical details. Using MRI, we can assess important features such as extracapsular extension, which indicate spread beyond prostate capsule, as well as seminal vesicle invasion. MRI can also help identify lymph node metastasis and evaluate invasion into near structure, such as the bladder or rectum. These findings are critical or determining prognosis and planning surgery or radiotherapy or other treatment. So the T&M staging system used in prostate cancer assessment, where the T stage describes the size and local extent of primary tumor within or beyond the prostate gland. The N stage evaluates whether the cancer has spread to regional lymph node. Finally, M stage refers to distant metastasis, meaning whether the cancer has spread to other parts of the body, such as bone or distant organ like brain or liver. Together, all these stages, the T&M system helps determine disease severity, prognosis, and the most appropriate treatment approach. So this is explanation in this slide. Summarize the T staging of prostate cancer, where T1 and T2 tumors are generally confined within the prostate gland. T2 diseases is further dividing based on the extent into involvement within one or both lobe of the prostate. T3 indicate local advanced disease with extracapsular extension or invasion of the seminal vesicles. And T4 represent more advanced spread into nearby structure such as bladder or rectum, where MRI is particularly valuable in identify these feature accurately. In this slide, describe the end staging for lymph node involvement in prostate cancer. NX means the lymph node were not assessed, while the N0 indicate the examined lymph node show no evidence of cancer spread to the nearby lymph node. N1 refers to single lymph node less than 2 centimeter. N2 indicate one or more lymph node between 2 and 5 centimeters. And N3 refer to the lymph node involvement where the largest lymph node is greater than 5 centimeters. This slide describes the M stage, which assists distant metastasis in prostate cancer. Similar to N stage, MX means that distant spread was not evaluated. M0 indicates there is no evidence of metastasis. And M1 means the cancer has spread beyond the prostate to a distant site, most commonly to bones, lymph nodes, or other organ. So the key aspect of prostate MRI technique include the use of phase array surface coil regarding the manufacturer or the company name of the coil, or we will use an endorectal coil if available. So the endorectal coil is the one shown in this picture, and in some hospital they provide this sort of coil. Patient preparation may involve bowel preparation, also bladder emptying to reduce artifact and improve pelvic visualization. Antispasmodic such as Buscopan are also commonly used to reduce bowel motion if there is no contraindication to the patient, and to enhance overall image quality. So prostate MRI technique include an initial localizer followed by multi-planar T2 weighted image using small field of view. Additional sequence include axial T2 cube and axial diffusion weighted imaging with B value, with 3 B value, the 50 and 800 and 1400, and axial dynamic contrast enhancement 3D T1 imaging. A delay 3D axial T1 sequence of pelvis is also acquired to complete the protocol. So how is the normal gland appear? In the normal prostate gland on MRI shows a well-defined symmetric structure with preserved zonal anatomy. On T2 weighted image, the peripheral zone appear relatively high in signal intensity, while the central and transitional zone show lower and more heterogeneous signal. And now we have example for abnormal gland. So in prostate cancer, most commonly arise in peripheral zone, according to accounting for about to 70 to 80% of cases. A smaller proportion occurs in the central and transitional zone. So on this T2 weighted image, as you can see in the red red mark zone area shows a tumor located in the peripheral zone. Appears as a focal low signal intensity lesion compared to the surrounding normal high signal peripheral tissue. Traditionally, T2 weighted image in three orthogonal planes has been the cornerstone technique for staging prostate cancer. On T2 weighted image, prostate cancer typically appears as an area of low signal intensity with an irregular contours, which may distort the normal gland shape. As seen in this image, this helps in evaluating local tumor extent and possible extracapsular spread. So also prostate cancer is typically characterized on T2 weighted image by a rise of low low signal intensity within normally high signal peripheral zone. So on this axial T2 image, there is a focal low signal lesion seen in the right peripheral zone, as well as involvement extending toward the central gland, as indicated by the arrows. This contrast between the dark tumor and the brighter normal peripheral tissue helps in identifying suspicious lesion on MRI. On the axial T2 image, the tumor is identified as a focal area highlighted by the black circle. Typically appears as a low signal lesion compared to the surrounding prostate tissue. In the axial T1 image demonstrates both biopsy hemorrhage shown by the arrow in this area. This appears as a high signal on T1 weighted imaging and is an important finding because it can sometimes mimic tumor on MRI. On this image, the tumor is seen as being confined within the prostate gland, consistent with the T2 stage cases in the TNM system. The white bulk here indicate the intraprostatic tumor in this area, while the smaller lined arrow on the left side of the prostate gland outline the prostate capsule, as you can see here, that the capsule is intact and there is no invasion for the tumor. Another example, the findings are consistent with the T3 stages disease in the TNM system. As you can see, there is extracapsular extension of the tumor with invasion into the seminal vesicles, which are indicated by the black arrowhead. MRI can detect prostate cancer with high accuracy, but it is not currently used as a routine screening tool or for the general population. However, in cases where there is a rising PSA but a previous biopsy is negative, the question arises: do the patient still have to underlying cancer? In this situation, MRI becomes a very valuable by identifying suspicious lesion and guiding targeted repeated biopsy, improving the detection of clinically significant disease. The PROMISE trial, which means the prostate MRI imaging study trial, published in 2017, demonstrate an important shift in diagnostic pathway of suspected prostate cancer. The result showed that a multi-parametric MRI is almost twice as sensitive as traditional transrectal ultrasound guided biopsy in detecting significant prostate cancer. This supports a shift in clinical practice where multi-parametric MRI is used as a triage test to determine which patient actually need a biopsy. Helping to avoid unnecessary invasive. The biopsy ultrasound is invasive, and this helped to avoid unnecessary invasive procedure and improving diagnostic accuracy. The role of MRI in prostate cancer is continuously evolving with the development of a functional imaging technique. These techniques grouped under the umbrella of functional MRI. They are designed to complement conventional anatomical imaging. They include diffusion-weighted imaging, dynamic contrast imaging, and MRI spectroscopy, all of which provide additional information about tumor cellularity, vascularity, and metabolism, improving overall lesion detection and characterization. Multi-parametric MRI combines key functional technique, including diffusion-weighted imaging, or DWI, dynamic contrast enhanced imaging, or DCE, and MRI spectroscopy, MRSI. These together, these sequence improve lesion detection and characterization of prostate cancer. So, water molecule normally moves freely in a random pattern known as diffusion. In prostate cancer, this movement becomes restricted due to increased cellularity and dense tumor structure, making the DWI as important sequence for detecting suspicious lesion. DWI detect area where water diffusion is restricted in both the extra and intracellular spaces. This provides important information about prostate tissue at a cellular level. This helps identify tumor diagnosis. It is also a quick and simple sequence that is routinely included in prostate MRI protocol. On DWI, prostate cancer typically appears as a high signal area due to restricted diffusion. On the corresponded ADC map, the same lesion appear as low signal, confirming true diffusion restriction and supporting the diagnosis of the tumor. In DWI, increasing the p-value increases sensitivity to restricted diffusion. A higher p-values improve contrast between cancer and normal tissue. and the value of 1000 or more are typically used to detect prostate cancer. At higher p-value, although the sensitivity is to restricted diffusion improve, the image become increasingly noise and less clear. Therefore, the selected p-value is balanced between achieving a good diffusion weighted and maintaining acceptable imaging quality for accurate interpretation. In summary, a high p-value, typically greater than 1000, is recommended in prostate DWI to improve detection of restricted diffusion. An ADC map and ADC value provide a quantitative assessment of diffusion restriction, helping to differentiate benign from malignant tissue. The ADC map require a low p-value using 0 or 50 for calculation. In future, ADC value may also help predict treatment response earlier than conventional MRI changes. Diffusion weighted image has several advantages, including a short acquisition time, non-invasive nature, and high contrast between prostate cancer and normal tissue at high p-value. However, it is also has limitation. It has relatively poor spatial resolution and is susceptible to artifact. Degraded in patients with metallic implant, such as hip replacement, making it non-diagnostic washout compared to normal tissue. The term dynamic refers to the repeated sequential imaging performed over time after contrast. Malignant lesion typically demonstrate earlier and more more rapid in tissue. Dynamic contrast image is based on a serial of 3D acquisition performed before, during, and after bolus injection of contrast, requiring a high temporal resolution of less than 10 seconds. After intravenous injection, contrast passes from the arteries into the tissue microvascular, and quickly extravasate into the extravascular extracellular space. Dynamic contrast enhanced MRI can also be analyzed using a semi-quantitative time signal intensity curve. This curve compare contrast enhancement over time between tissues. In prostate cancer, the lesion typically show faster and stronger enhancement, represented by the, as you can see, the red line. Compare with the normal prostate tissue shown by the blue curve. These reflect increases in vascularity and more rapid contrast uptake and wash out in malignant tissue. Dynamic contrast enhanced imaging is performed using multi 3D T1 weighted acquisition before, during, and after intravenous contrast injection. It requires high temporal resolution, typically less than or equal to 10 seconds, to accurately capture the enhancement pattern over time. The overall acquisition lasts approximately 4 to 8 minutes, allow assessment of contrast uptake and washout characteristic in prostate tissue. The data can be analyzed using three main approach. The qualitative method is simplest, based on visual assessment enhancement curve. The semi-quantitative method extract measurable pattern from this time signal intensity curve, providing more objective assessment. Lastly, the quantitative method is the most complex, involving mathematical modeling of tissue perfusion and contrast kinetic. Dynamic contrast enhanced imaging offer several advantages, including improving detection of tumors and increase specificity when combined with the T2 weighted image. It allows the entire prostate gland to be assessed rapidly with excellent temporal resolution achieved over just a few seconds. However, it does require intravenous contrast injection, and the use of the injector system and the data analysis for the curve can be relatively complex compared to other MRI technique. MR spectroscopy MR spectroscopy is a functional MRI technique that analyzes the biochemical composition of prostate tissue. It measures the concentration of key metabolite, mainly citrate and creatine and choline, which are naturally present in prostate gland. In prostate cancer, the metabolite levels changes, particularly with an increase in choline and reduction in citrate, allowing metabolite characterization of suspicious for the lesion. MRI spectroscopy provide both anatomical and metabolic information about prostate tissue, allowing better characterization for the lesion. It is commonly uses the PRESS technique, which stands for the point resolved spectroscopy, to obtain localized spectral data from the prostate. Multi-saturation band applied and are also to reduce the unwanted signal from the fat, improving the quality and accuracy of the metabolic information obtained in the curve. In summary, MR spectroscopy evaluates metabolic changes in prostate tissue. Healthy prostate typically shows higher citrate level. In prostate cancer, citrate level decreases while choline level increases due to increased cell membrane turnover. This metabolic changes help in identifying and characterizing malignant tissue. MR spectroscopy is technically demanding and time-consuming compared to other MRI technique. It is still mainly considered as a research tool and has not yet become part of our routine clinical practice. For this reason, it is not widely used in everyday prostate cancer imaging at present. We almost there. In summary, we have reviewed the current role of MRI in prostate cancer staging, include its importance in clinical decision making, we covered the basic anatomy of the prostate gland, as well as the key Gleason score system and the TNM staging use of risk stratification. We also discussed the typical MRI appearance of prostate cancer and how multiparametric MRI technique improve detection and characterization. Finally, we highlight the evolving and future role of MRI in the diagnosis, staging, and management of the prostate cancer. Thank you for your attention. I would be happy to take any question.
الله يعطيك العافية أستاذ فهد.
الله
شكرا
يعافيك.
على المحاضرة القيمة، والله استفدنا كلنا. الله يعطيك العافية.
الله يعافيكم جميعا، إن شاء الله أنه الجميع استفاد،
الله يسلمك.
والله يعطيك العافية إن شاء الله.
شكرا على وقتك حبيبي، شكرا. الله
الله
يسلمك.
حفظك الله.
الله يعطيكم العافية جميعا، شكرا للحضور.